Okay, I think we can get started. I know we're going to have some additional folks joining us, so we'll just get going in the interest of time. Good evening, everyone. Thank you so very much for joining us. I know for many of you it's late, and we appreciate your time. Today marks the exciting launch of our MedTech Unplugged webinar series brought to you by the Navro platform. And this is a series where we are going to be featuring world-renowned experts who are going to share their knowledge and their insights across various sectors of the medical technology industry. And our series has two key goals. First, to expand your understanding of the dynamic and ever-evolving world of medtech, helping you to explore and hopefully identify areas of particular interest to you. And second, to equip you with valuable insights and knowledge that will prepare you for interviews as you make the transition into the workforce. This really is a unique opportunity to hear directly from industry leaders, engage with them, and really deepen your understanding of the field. Your active participation in this series will not only broaden your perspective, but will also set you apart as a more informed and competitive candidate in your job search. So without further ado, it is my absolute pleasure to introduce our esteemed speaker for today's webinar, Dr. Ulrike Burgerstotter Green. Dr. Green is a leader in the field of cardiac pacing with an extensive background in both clinical and research settings. She's a cardiologist who specializes in electrophysiology and cardiac devices, and she's made significant contributions to the understanding and advancement of pacemaker technology and cardiac rhythm management. Dr. Green is currently the Director of Pacemakers and ICDs at the University of California, San Diego. Her work focuses on the intersection of engineering, medicine, and technology, where she's been at the forefront of innovations that have shaped the field of cardiac pacing as we know it today. Dr. Green will guide us through the evolution of cardiac pacing, examining how far we've come from the early days of the technology to the modern life-saving devices that are in use today. She'll discuss both the engineering advancements that have made these devices really more efficient and reliable, as well as the clinical implications that have improved patient outcomes worldwide. As students and faculty in engineering and health sciences, you'll find Dr. Green's insights particularly valuable as we explore the critical role that multidisciplinary collaboration plays in shaping the future of biomedical engineering and health innovation. So please join me in welcoming Dr. Green.
Well, thank you very much, Jenny, for that very kind introduction. And I am very, very happy to participate in this. I think this is a fantastic initiative, and I love that, again, medicine and technology can work together. So I'm happy to be here, and I'm talking about myself, what I do as an electrophysiologist, and a little bit about pacemakers. I am going to start sharing my slides. And let me minimize that. All right, cardiology and technology, we are indeed in this together. These are two fields that overlap in so many ways. As a cardiologist, we couldn't work without our phenomenal engineers that put together things that we ask them to do that are just amazing. And likewise, I would say that the engineers and the technology wouldn't have anything to do if we didn't work together. So fantastic collaboration. You heard a little bit about me already, but this is me. Jenny, you did a good job pronouncing the whole name. I really go by Ulrike Green. I went to medical school in Stockholm, spent some time at UCLA, and the road to do what I do then goes through then doing a residency in internal medicine, which I did at Vanderbilt, and then a fellowship in cardiology and another fellowship in electrophysiology, and this was then at UCSD. I have stayed there since then and been on faculty now for many years at UCSD. and am a professor of medicine in cardiology, and for many years also the director of the pacemaker and ICD service at University of California in San Diego. So what does an electrophysiologist do then? Well, electrophysiology is a subspecialty of cardiology. We then specifically focus on heart rhythm diseases. Things that you might have heard of that are very common would be something like atrial fibrillation, sudden cardiac arrest. We do pacemakers, defibrillators, procedures for atrial fibrillation. All of that falls under electrophysiology. It is a very procedure-oriented specialty, so lots of fun tools and lots of technology every day in what we do. I put this slide in here just to kind of show you this is what it looks like where we work every day. You see a cath lab there, so patient on the table with fluoroscopy to let us kind of find our way in the heart. And also lots of mapping equipment. On the other picture, you can see a colleague doing an ablation procedure there. So again, you can see surrounded by tools and equipment to help what we do for our patients. A typical work week for me and for many electrophysiologists, I suspect, is a Monday. I do a very specific type of procedure called lead extractions, meaning I actually take devices and these type of leads out of patients. Tuesdays is I see patients in an outpatient clinic, and then I put pacemakers and defibrillators on in that afternoon. Wednesday morning, we have a didactic conference that is available for our EP fellows and cardiology fellows, and then I see patients, again, in outpatient setting. Thursday is another didactic conference, teaching conference, and then I go to that EP lab. You saw that one with all these screens and fluoroscopy, and do procedures all day. Friday, I'm lucky enough to have a day when I can actually try and catch up on all the things that I didn't do during the week, which is going through our remote monitors, do meetings. Everything we do is on Epic, which is in our medical record system. And I also try to find time to work on clinical research projects. So let's talk a little bit about pacemakers then. I was thinking about what would be good for you to hear about. And I thought pacemakers is really kind of a perfect introduction into that intersection between technology and how we can help our patients. And it's also something that has been around for a long time, but has come a long way since we first started putting pacemakers in. So what is a pacemaker then? Well, it's this little implantable device that helps regulate a patient's heart rhythm. It does this by generating electrical impulses. That pacemaker produces then electrical impulses through a generator that typically sits under the skin and stimulate the heart muscle to contract. These impulses that are generated then are sent along the generator through these wires, or we call them leads, that are implanted into the heart. So now you have the lead and you have the generator, and now this system can control the patient's heart rate and then kind of adjust the frequency of these electrical pulses to make sure that the patient has the desired heart rate. Some specific type of pacemakers then also can coordinate the contraction of different heart chambers. Important to coordinate the top and the bottom chambers. Also, for some patients, important to coordinate the bottom two right chambers, the right and the left side. All of this then to help the heart pump more efficiently. Why would you get a pacemaker? The typical conditions would be something called bradycardia, which is a slow heart rate. So these are patients who may be feeling dizzy or lightheaded, or may not feel like they can walk up a flight of stairs anymore because they just can't get their heart rate up. A typical heart rate should be averaging 60 to 70, a little slower at night, a little higher during the day, and certainly higher when you're active. But some patients may not be able to get that heart rate to where it should be. Another indication for a pacemaker is a heart blocks. That is when the electrical signal that is generated in the heart can't work its way down the electrical system and kind of stops somewhere, and the heart can start to maybe beat, just instead of beating regularly top to bottom, top to bottom, top to bottom, maybe it's top, bottom, top, nothing, top, bottom, top, nothing. And the patient's heart rate goes from 60 to 30. And you can imagine that is clearly going to make a patient not feel good at all. It can also help irregular heart rhythms. That would be under the times when patients have atrial fibrillation that we need to be able to better control, and we can combine pacemakers and medications. And lastly, sometimes also for heart failure, which is when the heart can't pump the blood out adequately. And that is when making sure that we have that connection top to bottom and right to left by pacing can make the heart pump better and help the patient's heart failure symptoms. So as you can see, there are a lot of different indications for pacemakers, and we are also putting a lot of pacemakers in these days. I'm going to show you here just what it looks like. On one side, you have the patient's, you have a normal electrical system. The yellow there, that is how the heart's electrical impulses normally works its way down the heart. You can see where it says sinus node. That is where every heartbeat starts. So if you have no problem with your electrical system, it's going to start up in the sinus node, and then the electrical impulse is going to work its way down that yellow path, well, over to the left side of the top left chamber, but then follow the yellow path all the way down to both the right and the left part of the heart and make the heart contract. That is a normal electrical system. However, things can go wrong, and they can go wrong almost anywhere along those yellow lines that you see there. And when that happens, then you see what you get on the right picture, which is then a pacemaker. And here you can see the generator. And in this patient, we actually have 3 wires or 3 leads inside the heart. You can follow those wires from the generator that sits under the patient's skin and fat tissue. The wires go into the bloodstream. That's the blue vein that you can follow there, and then into the heart. And you have a wire in the top right chamber helping that sinus node that you see on the other picture. You have a wire in the bottom right chamber helping the right side of the heart. And in this patient, you have a wire over to the left side helping the electrical system on the patient's left side. This is the patient who got the very first implanted pacemaker. So his name was Arne Larsson, and he got the pacemaker in 1958 at my alma mater, the Karolinska in Stockholm, Sweden. He was a 46-year-old engineer, in fact, who had the heart block that we talked about, and he kept passing out. And his wife said, you know, we've got to do something. I have heard that there is this new thing called a pacemaker. I think you need one. So she put him in the car, drove him from a town way outside Stockholm into Stockholm to the Karolinska, basically told them, I think Arne needs a pacemaker. And indeed he did. He got a pacemaker. He lived many, many years after that. He actually lived to be well over 80 years old. And when he turned 80, there was an interview with him in the Swedish main newspaper. And he was very proud of the fact that he had, in fact, outlived both the surgeon who put the pacemaker in and his cardiologist. He had a long history of pacemakers. In his lifetime, from when he was 46 to when he passed away in his mid-80s, his first pacemaker, I think, lasted less than a day before the batteries ran out. So over time, he had 26 pacemakers, and again, lived a good, long life, and he truly saw the development of the pacemaker. So as I mentioned, we put a lot of pacemakers in. This is just to show you the number of pacemakers as an example that we put in here at UCSD. So you can see here in 2007, we put just over 100 pacemakers in that year. And in 2023, we put 343 pacemakers in. And I think this is very representative for what goes on really around the country and for the most part around the world. And we put many more pacemakers in partly because our patients are getting older, and that electrical system we talked about, the main reason why it starts having problems is older age. So having a patient population that is now well trending into the 90s, we're going to see many more patients needing pacemakers. But you could also see that the indications are expanding as we're treating more patients for heart failure, as an example. So we talked a little bit already about what a standard pacemaker system looks like. This is a standard transvenous pacemaker system, meaning that we are using the patient's veins to get the leads into the heart. You see that here again, the pacemaker generator is typically implanted on the patient's left side under the skin and under the fat tissue. We use the left side partly because we like to stay away from the right side. If a patient is right-handed, you want to put it in where on the side you're going to use less. And it's also anatomically a little bit more favorable on the left side. So in this case of the standard transvenous pacemaker, the leads then go into the blue vessel there you see, which is then the vein, and into the patient's heart, a fairly straight shot through the what we call subclavian vein into the superior vena cava, and then into the patient's heart. And this is then, in this case, it's a dual chamber pacemaker, meaning a lead in the top right chamber, the right atrium, and a lead in the bottom right chamber, the right ventricle. So in this patient's case, he or she would have the capacity to pace both in the top and the bottom right chamber. This has been the pacemaker we have now put in for about the last 25 to 30 years. And these pacemakers have come a long way. So what we certainly have seen is they get smaller and smaller and also get better batteries. So an average pacemaker that you just saw, the battery is going to last around 10 years. The battery sits in that generator that you see here, then up under the skin and under the fat tissue where it says pacemaker. That is the pacemaker generator. When the time comes for a new battery, we don't pull batteries out and stick batteries in. Again, we actually change that whole generator. They have something very helpful to patient, which is rate response, meaning if you have a patient who has a very slow heart rate, you want that heart rate to go up when the patient is active. So that is rate response. So now it can almost function like your heart's normal electrical system. These little pacemakers are really also very good monitors. We can see exactly what goes on with the patient. So when a patient comes in, we can tell him or her, oh, I see that you had some atrial arrhythmias, some atrial fibrillation 5 weeks ago, and the longest episode was 6 hours. All of that is there for us to review. Overall, they now have very sophisticated algorithms. All devices are approved to have MRI scans, which used to be a big problem with older pacemakers. And most importantly, I wouldn't say most important, but very importantly for the patients and for us too, we can monitor these pacemakers and know exactly what's going on with them without having to have the patients come into clinic to see us every 3 months or every 6 months. This is these days all done remotely. This illustrates here how far we have come with remote monitoring. So when I started doing this now many years ago, we had trans-telephonic monitoring, and you can see what that was like. The patient had to be at home. He had to put these little sensors on his fingertips, and this went through the phone to us. And really, the only thing we could see at that point was that the patient was in fact still alive, and you could assess how much battery life was left. The next thing that happened with remote monitoring was that instead of sitting there with a telephone and sensors on the fingertips, they got a remote monitor, and they had this little wand, and you can see that it says inductive. So every 3 months, we would tell the patient, we're going to check your pacemaker. He or she would have to be home. They would put the wand over the device, push some buttons, and that would then through kind of a secure filter come to us, and we would see it. That was a vast improvement because we could suddenly see much more that was going on with the pacemaker. But you could also imagine the patient actually had to be home, had to be scheduled, had to understand to put the wand over the device and do all of those things. So the next thing that happened was that it became completely wireless. So now you have a remote monitor next to your bed, and you really don't have to do anything, because the remote monitor will then wirelessly at about 2 o'clock in the morning go check the device while the patient is sleeping. And every 3 months go through this secured filter to us, and we would see everything that goes on with the pacemaker without the patient having to do anything at all. Also, if there's something wrong with either the pacemaker, if the patient is having heart rhythm problems, then it will always go through the filter, no matter if it's been 3 months or not. So this way is a way for us to really truly be able to monitor the patients. Even better though would be to do this completely app-based. So what we're trending to now with remote monitoring is the patient gets a pacemaker implanted, and we tell the patient, we're going to check your pacemaker, and we're going to do that through an app on your phone. And then the patient gets the app uploaded, and we can, as you can see here, then follow closely through app-based monitoring everything that goes on with the pacemaker. So you can see that remote monitoring has come a long, long way in just a few years. This is an example of, the data that we see. So the data on remote monitoring is incredibly granular. We can look to see, has the patients had abnormal heart rhythms? If so, when? How long? When did it happen? All of that is available for us to see. So you would think that maybe we're done, say we have come such a long way with pacemakers that there's nothing left to do. But I have very good news for you. There's many things left to do in the world of engineering and pacemakers, because it's far from a perfect technology. And there are some issues with the transvenous pacemaker that I just showed you. That generator under the skin, that is problematic from infection. You can get, sometimes you can even see that generator kind of erode through the skin. Those leads that go in, the leads can nick the tip of the lung and cause the lung to deflate, which is something that we would have to fix at the time of the implant. The leads can go bad. You can imagine these leads, they have to bend and work, bend and mold. This repetitive motion increases the risk for lead fractures. Overall, as good as these transvenous pacemakers are, there are definitely things that we can hope we can do better. And this is where leadless pacemakers come in. So in my son's hand here, you can see the entire pacemaker. So this is what an example of a leadless pacemaker. And in a drawing, it would look like this. So you see there's no generator under the skin. There are no leads going through the veins into the heart. This is it. This is the entire pacemaker. This is implanted on the left side here. You can see how we actually implant that through a vein in a patient's groin. So this is a long delivery tool that I have my hands on there that goes up into the heart. On the right side, you can see the leadless pacemaker implanted in the patient's bottom right chamber. We pull that long delivery tool comes out from the patient's groin. We put the stitch out in there. The stitch comes out the next day, and the pacemaker is in place. Why is this so good? Well, you know, there's no pocket. So no pocket related complications, you know, no infection erosion. There's no lead, so you're not going to have lead related complications. Because I say, as good as those transvenous leads are, they are the weakest link, and you can avoid a lot of potential issues there. And overall, there's a significantly reduced risk of infection with leadless pacemakers. The next step, which is what we're also doing now, is doing 2 leadless pacemakers. So you remember how I showed you the picture of a transvenous system with a lead in the top right chamber and a lead in the bottom right chamber? Well, this system would replace that. So here you have a little leadless pacemaker in the top right chamber and a leadless pacemaker in the bottom right chamber. And these 2 pacemakers can then communicate with each other using the bloodstream to maintain communication. And that's how you then have communication again between the top and the bottom chambers of the heart. These leadless pacemakers are made to take out. So when the battery runs out here, we will be able to take them out and replace them. Leadless pacemakers are now also combined with defibrillators. In this case, you can see a leadless pacemaker. And in this animation or drawing here, this patient has a defibrillator placed under the skin and under the fat tissue there in the on the side of the chest. So 2 devices combined in one. Here's another example of where we're moving away from leadless pacemakers. This is a patient where we use ultrasound to generate electrical impulses. So this patient has a regular pacemaker, but to avoid putting a lead over on the left side, you can put a little, and you see the electrode there, which is a 9 millimeter long electrode, gets implanted directly into the wall of the left bottom chamber of the heart and is generating impulses through an ultrasound device that is implanted on the patient's side. Well, what would we like to see in the future then? What is the problem? Well, I will say that one of the weak links overall is battery. I mean, it would be fantastic if we didn't have to worry you know, about every 8 years or so about the patient's battery. So a lot of interesting thoughts coming along here. This is an example of a solar powered pacemaker then. This is an in vivo, an ex vivo model in pig skin. So skin is very capable, has very good penetrance for infrared light. So you can then imagine that this little device could harvest sun energy and generate battery life that way. Another possible way to generate energy would be to harvest the patient's own heart muscle motion. And what you would do there then is convert this motion into electrical energy. All potential thoughts for long-lasting batteries. No, what about the leadless pacemakers? Could you do something there? This is a completely proof of concept study here, but in this case, they have a leadless pacemaker and they use a piezoelectric film, wrap the piezoelectric film around the pacemaker kind of as a coating or a housing. And the piezoelectric film then integrates with the internal circuit here to help recharge the battery. I don't think this is going to potentially impact battery life a lot, but if something like this could maybe add a couple of years to the pacemaker battery life, that would every year would be welcome. All right, but here's a whole different concept. So this is taking pacing down to a nano generator size level then. So this is a in vivo model in a dog, I believe, where you have a piezoelectric generator, nano generator that can harvest biomechanical engineering from each cardiac pulsation. So what you see here in this model then is valid pacing spikes. So the device releases electrical stimulation, this nano generator, at 3 different sites. So you can see right atrium, left ventricle, and his bundle at all these different sites. This all-in-one kind of flexible piezoelectric nano generator can create a valid cardiac impulse. Other thoughts, this is from University of Texas. So what they created was an injectable and hydrogen electrode. This is injected into the coronary veins. And once it gets injected into the coronary veins, then this it kind of fills the coronary veins and converts them into a flexible electrode that can then reach down into mid-myocardium, which is kind of in the middle of the heart muscle. If you think of the thick heart muscle, if we could actually get into the middle of the heart muscle, this would be a way to do that. If you get this electrode, then it creates these like flexible highways, as they say here. You could potentially stimulate the heart muscle at several different points at the same time, which would be really more physiologic than just this point pacing that we have had up until now. And then lastly, biological pacing. Using embryonic stem cells or pluripotent stem cells to develop biological pacemaker, or viral vectors. You could do viral vectors and induce a sinus node. So now maybe the body will create its own new sinus node. So I think we have come a very long way. In 1958, Arne Larsson, the patient in Stockholm, got the very first pacemaker. That was open heart surgery with a big generator, the first one lasting less than a day, and this lead that sits directly on the heart and did very little, to where we are today with a mix of these leadless pacemakers and still transvenous pacemakers, to the future where illustrated that here with the viral vector delivery, which is that blue little dot. And then you have created a biological pacemaker, which is the orange dot. We are absolutely not there. And as you can see, there are many things that we're speculating about, but we don't have yet. And I'm going to count on all of you guys to think about all of these things and help us and, be the creators of the future of cardiac pacing. Thank you very much for listening to all of this.
Thank you so much, Dr. Green, for that amazing and highly informative presentation on really the evolution of cardiac pacing. I'm sure several folks in the audience have questions, so if you do have questions, please feel free to type it into the chat, or you can even unmute yourself. And I'm going to kick it off with a couple questions myself, actually, while we're just waiting for those to come in. So Dr. Green, as an electrophysiologist or an EP, in cardiology, I wondered if you could help explain to the audience the differences between someone like yourself as an electrophysiologist versus an interventional cardiologist and just a general cardiologist, just so they have an understanding of it.
So an interventional cardiologist is the cardiologist who would, as an example, treat patients who need a stent. So patients who come in with a heart attack and they need a stent put in urgently, or at some point in time, that would be an interventional cardiologist. We jokingly said that the interventional cardiologists, they are the plumbers, and the electrophysiologists, we are the electricians. I think that's pretty much right on.
That's a great way to categorize it. Okay, I'm going to ask one more question, and then we've got a few coming into the chat. So I know you've had an opportunity to interact with R&D teams in the industry on the development of new technologies. And a question that had come through is, what does that relationship and collaboration look like?
So that the very nice thing about being at an academic center is that we do get many opportunities to participate in say, a clinical trial. So an industry may come to us and say, we have a new defibrillator. And we want to try that out in patients in clinical trials. And we, of course, love to be able to do that. And it's a way for us to see kind of part of the cutting edge of research. But it's also, I'm an electrophysiologist who's been doing this for a long time, and industry might come to me and say, we have an idea. We are thinking about this. Would you mind sitting down with us and talk to us about the possibilities? Do you think this is going to work? And sometimes it can be really big pictures, and sometimes it can be, we're bringing a tool to you. Do you like the color of it? So it goes from big picture to very detailed discussions about technology.
Wonderful. Okay, we have a question that's come in asking, how were researchers able to create pacemakers that are allowed in MRIs?
Oh, so big question. There are two components to it: the generator and the leads. When pacemakers were not allowed for patients to have an MRI, this was before the leadless pacemaker. So the old transvenous pacemakers then had two components: the generator and the leads. So the first thing that they needed to do was to make sure that the generator would tolerate the MRI, the heating, the possible effects on those fancy algorithms. So they were able to secure the algorithms within the device. The other component was the leads, and the concern was that the leads would transmit heat, and that heat would work its way down the lead and maybe tickle the heart muscle and cause bad things to happen. So they had to then redesign the leads a little bit, make them a little smaller, adjustments so that they would tolerate an MRI. Even before that, though, I think that the MRI were probably generally safe, but they certainly are now.
Great. Okay, we've got another question. It says, earlier you mentioned that a pacemaker is able to compensate for an increased heart rate during exercise. Can you elaborate on how this happens?
So the phenomenon is called chronotropic incompetence. That means that a patient has a difficult time getting an appropriate heart rate response with activity. So that patient is typically an older patient in his or her 70s or 80s, and the baseline heart rate may be 45. And then the patient tries to go up the stairs, and it's still 45. Goes take the dogs for a walk, and it's still 45. And that is a very uncomfortable feeling for the patient. So the patient now gets a pacemaker. So now the pacemaker, through either a piezoelectric crystal in the generator, knows when the patient starts to be more active. There are other ways to sense activity. The piezoelectric crystal is called an accelerometer. There are other ways, and there's something called a minute ventilation that picks up on respiratory patterns. So there are different type of devices. But the pacemaker now sees that the patient tries to do something. So now the patient is out walking the dog, and instead of having a heart rate of 45, this rate response mechanism kicks in and starts driving the heart rate up as if the patient had a normal heart rate response. And those can be adjusted, so the patient can come in and says, Dr. Green, can you make that heart rate get up a little bit more? I need a little bit more energy. And then we can adjust those things to kind of fine tune it to each patient.
Great. Thank you.
It's actually, I'm going to say, one of my favorite indications for a pacemaker, because those patients feel so much better afterwards.
Oh, I bet.
Yeah.
That's a good feeling after they've had that adjusted.
Mm-hmm.
Okay, a few more questions here. Could you re-explain about the cardiac pacemaker that works with ultrasound?
Yeah, so that is a very it's a new concept, and it's this particular device is still in clinical trials, but the idea is that you put in a little device in the patient's in the side of the chest that generates ultrasound impulses. The little 9 millimeter receiver is inside the heart. So the impulses comes from the device that's implanted on the side of the chest, being picked up by the receiver, which is there inside the patient's heart, and that receiver generates an impulse.
Wonderful. Okay, I've got one more here coming from the chat. For leadless pacemakers, how does it resist movement due to contractions of the heart? Does it get anchored to the different chambers?
Oh, yes. So we definitely need to anchor it. Yeah, if we don't anchor it well, there's certainly a possibility that leadless pacemaker could be on the loose, and that we would not like that. So these are anchored in, there are two different ways of anchoring. One has these little nitinol tines that kind of grabs onto heart muscle and in fact, holds on to it very well. Those are holds on to it so well that they're not designed to take out. The other type of pacemaker has a helix, or like a little corkscrew mechanism that we deploy and can undeploy when we take those out. So those are designed to be removed when the battery is out. But yes, great question. We don't want them to go anywhere. They need to stay in place.
Great. I'll give it another minute or so to see if any more questions come up in the chat. But in the meantime, I'm going to ask a question on behalf of many of the audience folks, because I know that many of the candidates on the call tonight are interested in seeking roles for their first career opportunity in a field-based role that could provide clinical or technical support, working alongside experts like yourself. And many have asked for a description of what would the ideal nature of that working relationship with you and your field reps look like?
It kind of depends a little bit on where you are in your training and where you are in your career. It's always good to be able to find people that you enjoy working with, mentors and role models. So if you are, starting out in industry, I would really try to work with people who have patience to explain to you, to go over the technical aspects. Try, and if you're really interested in medicine and that, to get exposure to being in clinical situations, come to clinics, see what the interaction is between physician and allied professionals and patients and industry. I mean, it's an interaction on a daily basis. So trying to get that exposure, which I realize could be easier said than done, but I think you learn so much from it. And going in the room with patients, just kind of see all of that, because that's the incredible part of this, is that in the end, we're all doing this for our patients, physicians and the engineers and industry. The goal is always the same.
Absolutely. Thank you. Oh, I've got one more question coming in. Okay. For the pacemaker that uses the biomechanical energy generated by the heart, how is the initial energy obtained?
Well, that's where there are a couple of different ways, but the one way that I think is interesting is using the heart's own motion. And so, I mean, the heart beats 70, 80 beats per minute. Every time it beats, it's a contraction pattern in the heart muscle. And that it's taking that motion of each contraction and converting that into energy. I understand that concept. You, the biomedical engineers, need to explain it from there. I've just said about everything I understand about that. That's why we rely on smart biomedical engineers.
That's great. I think those are all the questions that have come in from the chat. So if anyone has any last questions, type them in now. And in the meantime, Dr. Green, I just want to thank you so very much for your time, for your expertise in sharing with us this whole journey of cardiac pacing and where the technology has been and where it has come through. Getting a lot of thank yous in the chat. This has been extremely informative for everybody. And we really appreciate the opportunity to hear from you and to ask you all these questions. Thank you so much.
My pleasure. Wish everyone here that wonderful careers, and I look forward to working with you.
Thank you so much. Good night, everybody.
Yeah. Bye-bye.